Good morning and welcome to the North Shore Outcomes Research Health Equity Research Series. Today, we're delighted to be joined by Dr. Marcia Tan, who will be presenting her research adapting a tobacco cessation training curriculum to promote intervention delivery among community health workers, results from a mixed methods community engaged study. We will also be joined by an expert panel, including Dr. Dan Fridberg and Anna Feliz Wilkins from the University of Chicago and Dr. Nancy Zhao from Rosalind Franklin University. I'd like to start off by thanking everyone who's been working on the front lines, from community-based organizations to clinics, from community engaged research labs to public health practitioners in the quest for promoting health equity. My name is Sean David. I am a program director for translational science and outcomes research network at North Shore. And Rachel Brewington is the administrative assistant for Outcomes Research Network, and she is my co-pilot for this webinar series. Overall, I'd also like to thank the North Shore leadership and our director, Dr. Susan Fisher, for sponsoring this seminar series. Our goals are really to try to promote research across not only North Shore, but across the 6 institutions of the Institute for Translational Medicine and the larger academic communities of Chicagoland. And we want to promote uniform access to care that's effective, efficient, and equitable, enrich the practice of medicine, and support clinical quality and operational decision-making through outcomes research. The objectives for our seminar series are to disseminate research that advances health equity in our health systems, in our communities, promotes policy change to promote equitable care and outcomes, and to advance translational science of health equity research. We want to support flourishing clinical investigators and collaboration and networking and team science. And we also want to bridge our researchers to their peer communities across Chicagoland and promote diversity, equity, inclusion, both in our presenters as well as in the topics and the goals of this work, ultimately delivering outcomes that improve patient and equitable health outcomes for communities. Next slide. So I'm going to hand this over to Rachel to go over the continuing medical education information and some of the nuts and bolts of the Zoom process.
Thank you so much, Dr. David. Hello, everyone. For today, to mark your attendance and claim CME, you'll just use the code on the screen and text that SMS code to the number you see on the screen. The University of Chicago Pritzker School of Medicine designates this live activity for a maximum of 1.5 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Other healthcare professionals will receive a certificate of participation. For more information on the applicability and acceptance of certificates of participation for educational activities certified for AMA PRA Category 1 credit from organizations accredited by the ACCME, please consult your professional licensing board. I will be sending more instructions of how to retrieve your CME credit in an email after the seminar. In today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you are on a computer, you can access this icon by hovering your mouse over the bottom of your Zoom screen. Please give special attention to the audience of your message before you submit it. As you can see on the image to the right, you can choose to message either the panelists and the speakers, this will include myself, or you can choose to message everyone on the webinar. Feel free to leave your questions and comments at any point during the presentation. If you're experiencing any technical difficulties, please let me know by messaging all panelists and I will assist you to the best of my ability. Thank you so much.
Thank you so much, Rachel. And please, we encourage people throughout the presentation to start entering questions at any point. So I'm going to go over an agenda for the seminar. It's a lecture discussion format. We'll start off and we'll introduce the speakers. And we will have a presentation that goes until about 11:40. During that time, any comments, the comments section questions will be reviewed by Rachel and I, and we will present those to the speaker. And we have about 10 minutes for Q&A. You can also enter questions during that Q&A session. And then we'll have our Incubator Hub expert panel discussion with our three panelists that I will introduce after Dr. Tan's talk, but Dr. Fridberg, Dr. Zhao, Anna Wilkins, and we'll go over the implications of this work for health equity. And then we'll have some closing remarks, and Rachel will provide a link to an evaluation, and then follow up with information about CME, credit claiming, and so forth. So it is my pleasure to introduce Dr. Marcia Tan, who is an assistant professor in the Department of Public Health Sciences at the University of Chicago, who is presenting her work on community engagement and tobacco treatment training. Dr. Tan, welcome, and we'd like to hand this over to you.
Excellent. Thank you very much for having me. Let me take a moment to share my screen. Okay, can you see everything well?
Yes.
Okay, wonderful. All right, thank you again for the introduction. I'm very happy to be here. My name is Marcia Tan. I'm an assistant professor at the University of Chicago in the Department of Public Health Sciences. My background is in clinical health psychology and epidemiology, and today I'm going to kind of walk you through the process of that me and my team have worked on for about a 5-year project so far on adapting tobacco cessation training specifically for community health workers, and then I'll present some results along the way too. And please, feel free to enter any questions that you have in the chat along the way. And I have nothing to report. These are my funding sources for the past 5 years of this project. All right, so I just want to start by saying that overall rates of commercial tobacco use in the U.S. have been declining steadily for the past several decades, ever since we found out the cigarette smoking caused cancer back in 1964 from the first famous, Surgeon General's report. You've kind of seen this steady decrease over time. But unfortunately, that's not the case for everyone. So if you look at certain subgroups of individuals or communities of people, these rates actually have kind of remained steady over time, particularly those with low socioeconomic status, such as low education, living below the poverty level, also those with disabilities, LGBTQ individuals, and certain races still have high rates. And this is the population that I'm particularly interested in, those subgroups of people who are still smoking. And so, one of the key problems that we're going to focus on, with our research is that many of these high-risk patients aren't really getting exposed to information on tobacco cessation. And we've done really well with establishing curriculums for tobacco cessation, treatments for tobacco cessation. We have a really strong evidence base there, but many of those occur in clinic-based settings, in hospital-based settings for current patients. And one of the issues is that many people who have these high rates of smoking don't regularly go to a primary care physician, for instance, aren't seeking healthcare regularly. They might be seeking healthcare in emergency department for emergency visits for other issues. And so our question is, how do we reach this population of people? And so we've been working with community health workers, again, for maybe about the past 5 years. And community health workers, I'm going to take a moment to kind of introduce, to you this workforce in case, you're not aware of them. But community health workers really are the bridge of the community members to the healthcare system. And so knowing that there are subgroups of people who have low access to care or are not, readily engaging with healthcare services, community health workers are really designed to connect those people to services. And an official definition of CHWs from American Public Health Association really identifies them as frontline public health workers, and they often come from the communities that they serve, and they're trusted members of these communities, and they really, facilitate the access to services and improve the quality of the service delivery. And because of that, CHWs, I'll abbreviate by CHWs, they wear many hats. So they really are unique in that they build these trusting relationships with the community, but they also engage in, other things like patient advocacy, cultural like mediation and, kind of making care more culturally competent. But increasingly, they've been doing a lot of health education and also really assistant with chronic disease management and helping to increase access to specific health services. Oftentimes, we'll talk about this a little bit later, community health workers are hired kind of to focus on a particular chronic disease such as asthma or diabetes, and they do a lot of like work around self-management around those things. And so because of the variability in how they, see the services they provide and how they, assist with patients, the role of a community health worker actually has become more official, and they've been really working to make this more of a, standardized process of, training to be a community health worker. And so the role was officially recognized in 2010 as part of the America Affordable Care Act as its own healthcare workforce, but unfortunately, the recognition really varies by state. Like for instance, Texas has a process to be officially certified as a CHW. Our state, Illinois, does not. But in 2014, Illinois really has they formed an advisory board. They're really trying to understand how do we sustain this CHW workforce and how do we standardize operations, but we still are in the process of it being very variable here. So with our work, I've done a lot of tobacco cessation work in the past. I'm really interested in understanding, knowing that community health workers are the ones who oftentimes will spend face-to-face time with patients that might not be seen in a traditional healthcare setting. How much do they know about tobacco cessation? Are they doing tobacco cessation? Is this something that we need to train them in? And I'm going to present the results of a needs assessment, in a second. And so our rationale is that they really can benefit from a condensed curriculum for tobacco cessation training, knowing that they do a lot of different roles and more supportive roles. So maybe a full training in tobacco cessation that it currently exists right now. So some of the trainings that exist, for instance, are freedom from smoking from American Lung Association. That was like an 8-hour training. It cost several hundreds of dollars. Might not be a good fit for them, and it might not be accessible to them. And so we were thinking that if we potentially modify the way a training is delivered for CHWs, that's going to reduce the barriers for them receiving the training and also give them the tools they need to see to offer tobacco cessation, interventions or brief counseling directly to the patients that are high risk, who aren't really being seen regularly in healthcare settings. And our long-term goal really is to develop a scalable, accessible curriculum for CHWs to use as they see these patients. And so this is an infographic that our coordinator developed, and this is kind of how we are thinking about this problem in the sense that there are a lot of really good evidence-based interventions that exist for tobacco for patients. Many of them, there is like the Tobacco Quit Line, there are community level resources, but the interventions that are housed in hospitals, a patient might go to, let's say once a week for an 8-week period, or they might, kind of have one-off experiences of attending these sessions. And then they might go home and still have issues with, quitting smoking because of all of their surrounding influences. The community health worker, they're designed to see the patients on these continuous basis in a very flexible way to address many of the social determinants of health that they have. And so they have this ongoing trusting relationships with the patients. And so we're really interested in thinking about how do we build capacity in this workforce? How do we support this workforce of community health workers as they are delivering their care, flexibly as they see fit? And so this is I'm going to walk you through this, but this is kind of our timeline of what we have done to really understand this. And our goal really was to adapt something for community health workers that was accessible to them, a training that was accessible to them, and then to evaluate, how they respond, their receptivity to that training curriculum, and to see if that training curriculum is effective. And so first, we really want to start off with a needs assessment, because we really want to know, is this something that is relevant or important? Are CHWs being trained in tobacco? Are there any gaps there? And so we started off with a needs assessment. And so first we did a mixed methods assessment. We started off with a survey. We developed a survey with the help of 2 community health workers. So we were really intentional about engaging community health workers throughout this entire process. And it was very telling for us because we started off with kind of a standard survey of trying to understand their tobacco cessation services, their knowledge about tobacco cessation, and then their any needs they had, any training needs they have as far as tobacco cessation. And the first pass of the survey that we created actually just did not make sense the way we were asking the questions for them. And so, a lot of it was, them, kind of telling us like, this is not, we like, you're coming from this perspective as a clinician. This is not how we see patients. We don't have one session where they come into our offices for, 10 minutes to, an hour. We don't have like a protocol that we follow. We might, but we have to really respond to the patients as we see fit. So we kind of had to change the way that we even asked the questions on this survey to get the information that we were interested in. And so we distribute the survey to both community health workers and lung health professionals, such as medical assistants, respiratory therapists in the Cook County area. We've also translated the survey into Spanish to see if the needs were different for our Spanish-speaking community health workers and those serving Latino populations. And then we followed that up with a focus group to get more information to kind of expand upon the survey results. And then we recruited 6 community health workers who are working in a community-based organization in the west side of Chicago. And so we followed up and to really get a better sense of the nature of the interactions they had with their patients, and also any potential more details about the gaps, the knowledge gaps they had and the training needs that they had. And so what we found from the survey results is that they do work with these high-risk groups. They do work with patients that have several comorbidities, many of them that have chronic illnesses, some experiencing homelessness, mental health issues, substance use disorders, and also a majority of racial ethnic minorities. But when we asked community health workers about addressing tobacco use, they said that many of them said they did ask, but very few reported feeling confident in addressing it. And then notably, overall knowledge, we gave a knowledge assessment of about 10 questions about tobacco cessation, about the general categories of smoking rates in the US, tobacco cessation strategies, and the nicotine addiction in general. And the knowledge was very low overall, with like an average score of about 4 out of 10. And it's interesting, very low rates of correct responses on what is considered an evidence-based treatment for tobacco cessation. That was notable. But many did know that, people really did want to quit smoking, and people, many believe that, brief counseling was an effective, strategy to help people quit smoking. But there really was this, absence and knowledge of really how to do that, what that looks like, and what the nicotine addiction is. And for the focus groups results, we, some of the major things that we found was that, there is a really great flexibility in how CHW see their patients. And, to kind of describe it, in their words, they're very responsive and reactive to their patients' needs. And that is like the key for them to really help address those, structural issues and social determinants of health to really get their patients connected to services. So, they talked a lot about their variable and where they see their patients. So some of them said they might see them, at a restaurant, or they might meet them at, their church, on Sunday, or even, in their homes, not necessarily in the hospital or the clinic, but they also will see patients and attend, appointments with them and things like that. And then also there's a variability in the number of sessions. And here's a few exemplary quotes. As far as the variability in the location of services, says we meet them wherever they feel comfortable. Sometimes we meet them alternative places because of pest infestation. So just commenting on, sometimes they can't meet them at their home. Then maybe have to respond and, address some things that might be happening with the patient in that moment. And then for the number of sessions, but we do it in steps. It's everything. They're not bombarded all at once with everything. It's in like pieces. So the idea of like how they see how they, work with patients as far as, improving their health, there's a lot of things that are going on with the patient. So they kind of take care to make sure that they are doing these things in steps too. So therefore they end up having these more longer term, consistent relationships with their patients. And then, something that was very notable that we learned from this focus group too, is that the way that current tobacco cessation training is delivered, or the way that the curriculum is designed, doesn't really fit with the way that they see their patients, or also with the, it doesn't really fit with, it's not relevant to their patients as well. And so we always want to ask and make sure, it's just like, are your patients smoking? Is this important? Like, do we need to be talking about tobacco cessation? And most of them were like, absolutely, yes. Saying like a majority of their patients smoke. And I remember in the focus group, we asked, okay, well, if you had to give me a number about how many, they were saying like all of them. We were like, no, like, what would you say, like over 90%? They're like, yes. And some were like even 99%. So like they are working with this group that has this high rates of smoking. But again, they really are responsive to their patients' needs. And so when talking about, there was one CHW who did do a formal tobacco cessation curriculum facilitator training to help me learn how to help people quit smoking. And it was a very structured like session where, she would run groups like once a week, and it'd be in a community center. So it'd be in their neighborhoods. And then one was speaking about a patient she had that went to one of these groups. And they said, I've received feedback from a person who participated in one of her smoking cessation sessions, and they thought it was really great. They thought it was very inspiring, very encouraging, but they just, again, they still had all of these surrounding influences and factors that just wouldn't allow them to completely detach from the behavior. So just really commenting on the social environment that these patients are coming from, the way that smoking cessation is designed, where it's just like, come to this session and let's talk about just quitting smoking. It doesn't really acknowledge well, like kind of all the recurrent stressors and things that the patients are going through. And we'll talk about that a little bit more, some more focus group results in a moment. And so from this, we realized there really is a need to consider this unique CHW care model and interventions that are really relevant to their patient population. And so next, we wanted to kind of think about, if we were going to adapt a program, how acceptable is that? Is this something that CHWs want? Is it something that they're interested in? And so we developed an outline of a training, again, trying to use kind of like an agile science approach to, kind of, get interventions and get things out as quickly as possible, instead of going through the process of developing the entire intervention or the training at once. We was like, let's just do an outline. Let's run it by CHWs. Let's see what they think about that. And so we did that. We developed an outline of like what an actual training would look like, as far as like how long it is, how many hours it would be, what the, how many sections it would have, and then the training content. And so we developed outline and also a draft of a PowerPoint slide. We recruited both CHWs and we conducted 2 focus groups with them, and then also 3 individual stakeholder interviews. So we also interviewed CHW managers to get their feedback on what the adapted training would look like. And so we did find that the training, this adapted training, was acceptable. So we gave them a measure to test the acceptability of this intervention, and then also was appropriate for their patients and their clientele. And so as part of that, the focus groups, we also, as I mentioned, we also ran focus groups to really get specific feedback on the content of the training and the impressions of like what a training would look like. And we found 4 major themes. First, something that came up throughout was that, for this patient population they work with, smoking is a main stress reliever, but not just, like, yes, I think you can like argue that that's many people do smoke to relieve stress, but particularly for like recurring stressors and traumas that are happening in their lives. And so the idea is that if this is a main coping mechanism, we have to think about how we're going to replace that coping strategy with something else, and something that's more adaptive and healthy in the midst of all of these like recurrent traumas that people are experiencing. And then next, I really want to talk about personalizing the smoking cessation to the patient's health needs, or how their behavior of smoking is related to their specific chronic condition, because many of them are seeing these patients because of a specific chronic condition like diabetes or asthma or heart disease. And so they really want to think about, this is what the patient is prioritizing. How do we kind of incorporate and get the patient to understand how smoking is related to those things? And then next, and this is a major theme, but also a sub theme throughout, is like motivation. So we approach this project thinking about, okay, we'll just take a standard intervention based on the 5 A's model, which is ask, advise, assess, assist, and then refer. Why am I forgetting the last A? Arrange follow-up. And so we were like, well, we'll take this brief counseling thing and we'll just kind of adapt it to what CHWs need. And then, they commented that the 5 A's is great. It seems like it's effective, but they were like, our patients are not at that point at all of being ready to quit. They're definitely, if they were going to use, health behavior theory terms, at the pre-contemplation state of thinking about quitting smoking. And so they're like, we really need to think about maintaining motivation for this patient population, and then thinking about, how we can personalize it to maintain motivation, because many of our patients understand the risks of smoking, but are very overwhelmed and not ready to quit. And then finally, they really asked for key language, especially associated with people who are not motivated or not ready. It's like, what do you say to a patient who knows all of the, harms of smoking, all of those things? They're just too tired. They have too much going on. They're trying to focus on, X, Y, and Z. Like, how do you respond to that? And so they really brought up the idea of needing to practice and doing role playing as part of a training. And then also really shifting everything to focus on motivation. And so that was the key for us, because we kind of shifted the way that we were thinking about structuring this training based on the 5 A's. And then we moved to the 5 R's, which is more motivation based. And then this is just a few quotes that I wanted to just show, just that kind of based on the themes that I just went over. For this example, thinking about motivation and maintaining motivation, and again, like personalization. Remind them you're quitting because you want to make sure that your blood pressure is low. You want to quit, just like something that motivates the patient. So when you're not talking to them every week, they still want to do it, because you can teach them all the material, but if they don't have the motivation, they'll start for a week or two and then they'll drop. And then the giving key points is like, literally they said, I want you to give me some talking points. Okay, they're not ready to quit. They already shared with me that they already know the dangers of smoking, and they're just not ready to be stopping smoking. That's where I want you to give me some talking points. And then also, again, discussing the context of their health conditions. I think another way we can be able to use them is based off why the patients are coming in. Like if I was working, doing cardiology now, they're coming in for heart and they're smoking, there's even more of a danger. I put that type of health risk on your heart when you're already on medications or you have a stent or something. So I think that's another good thing, that we can kind of correlate the reason or a little bit of their health issues to why they should probably stop. And then lastly, smoking is a stress reliever. A lot of young people tend to smoke because in our community, because of stress, because of the things that we may lack in the communities, or, it's a lot of violence going on within the Black communities too. So I think there's just these main points of this is a specific population that's working, that has these comorbidities, these comorbid chronic conditions, that smoking is related to most all of them, but they still have these recurrent stressors that are unique and significant in their community. So how do we address all those and kind of, take care of all of those when we're thinking about tobacco cessation training? And so what we did is, from these focus group results, from the data from our needs assessment and the focus groups, we took all of the considerations and we kind of developed this 2-hour tobacco cessation training. And what we did is, we started with the WHO toolkit for delivering the 5 A's and 5 R's brief tobacco intervention for primary care. We thought that was a really good framework to use to adapt to community health workers. And what we learned in it, there was a lot that we needed to cut out, a lot of background. And so I'm going to kind of show you kind of our steps of adapting right now. Got time, yes. So the idea is that we're not creating something new. So we're taking something that's evidence-based and we're adapting like sections of it and examples in it to be relevant to CHWs and their model of care. And so for instance, for the background on tobacco use in the WHO toolkit, they show a lot of graphs of like rates of smoking in the country and kind of the rates of decline and things like that. And so with feedback we got is that, they were like, we don't want to see graphs, like we don't really care about all of those things, but we are interested in, the structural history, of, why these groups of people have sustained, smoking over time. So really emphasize the tobacco industry's targeting, of minoritized communities and adolescents, like over the years to like really put it in context. And then we highlighted the unique role of community health workers in tobacco cessation, which is, similar but a little bit different than, traditional healthcare professionals in tobacco cessation, because they do have this like flexible care delivery model. And then for the impact of tobacco use, we emphasize this in relation to the other chronic conditions or behaviors that patients might be experiencing. And we also really want to focus on menthol particularly and co-marijuana use, because that's very, very prevalent in the communities that they're working with. And then we still included benefits of quitting, but instead of, kind of using that, including it in our 2-hour training, we include it as a handout, and we kind of went over that and kind of like gave it to them as a resource that they can hand out to their patients. And then for the challenge of quitting, one of the main things that we did is we developed case examples, and I'll talk about a little bit in the next few slides, to kind of walk through like the nicotine addiction and like why is it so difficult to quit, and focus really on the stress and like mental health, part of smoking and quitting. And then again, for the 5 A's, we really focus on the assessing motivation, seeing where their patients are, still presenting, kind of generally the 5 A's and kind of having resources as they walk through the 5 A's and to help assist their patients, but we really focus on motivational interviewing. And then we could create a handbook for motivational interviewing, particularly that's, kind of teach them how to flexibly complete the 5 R's, like as they continuously see their patients. And then so we actually took the first half of our training is kind of background, but then, we really talked about motivational interviewing, particularly. Many of the CHWs have had some standard training in motivational interviewing, but we really wanted to put in the context of smoking cessation and then kind of go over some of those principles. And then we actually practiced like those MI skills and did role playing and case examples. And so what we did, again, these case examples, that we really want to use the real life examples of what they might see to put in, again, the context of how they're helping their patients. And so we start off with a case, Mary, who is an older adult woman, and then Sean, who's like a younger adult, man, kind of like showing 2 different sides of stages of like motivation, to quit, but then also like, why is it so difficult to quit? So what does nicotine addiction look like? What is the comorbidities, all of those things. And at the end, we actually focused on example Brenda of what would you say to Brenda? So if you know that this is her history, this is, her situation, how could you start this conversation? How can you maintain this conversation with Brenda over time? And we got feedback, again, like after we developed this, we ran it by community health workers, and they gave us really good feedback that they really wanted to note where there are good talking points for them to use with their clients. So even when we present something about the nicotine addiction or tobacco industry, they want to say, okay, is this a good thing that I can tell my client, like as I'm like helping increase their motivation? And then again, I said we deleted content on the background information and provided examples that are relevant to their clientele. So there's an example of a slide that we have of kind of the intergenerational nature of smoking, and how Sean, has parents, in the household, or both parents that smoke. And then kind of the idea of like the targeting of the tobacco industry, targeting Black communities. And then also, tobacco and marijuana. And, our focus is not on cannabis use or cessation or anything like that. It's just like in the context of smoking and quitting smoking, how is this related? And that was this little like light bulb is like our talking point that they could say to their clients of, the smoking, the inhaling, the combustible nature of, using, marijuana is, it's harmful, it's damaging to your lungs, right? So without endorsing, use of it, this is how it's related to smoking and smoking cessation. And then next, what I'm most excited about that our coordinator, Clarissa, designed was we have this like handout of comorbidities to really to link it with what is going on with that patient. This is a way to really personalize it. And so we had maybe like 11 different ones: tobacco and diabetes, heart disease, cancer, HIV, weight, secondhand smoke, and we have like several different ones to kind of do the key takeaways of like how this is related, how the nicotine addiction is related to all of these conditions, and kind of like we design it so it's kind of like, here's something that might be interesting fact to you, and here's the key takeaway. And then this is like the more scientific things that, in case want more information about that. And then we also have a website that has all of this information on it too. And then finally, we created, again, most proud of this, Leanne Nicholson, one of the master students, created this motivational interviewing book where we actually give examples of responses. So we kind of group together kind of what a client might say based on being a certain stage of change or readiness to change. And then we responded with like, what's a motivational MI response to it? Like, what's a appropriate way to respond to this to keep the conversation going in a very non-judgmental way. And then we also have phrases to avoid down here of, the things that you might want to say, but it's probably not going to be effective for this conversation. So this is what you shouldn't really think about saying, but really focus on like how to keep this like going, right? So for instance, this is like, a patient in the pre-contemplation stage of like, I can quit whatever I want, not interested. And it's like, oh, okay. So what it look like when you are ready to quit, or like, that's great. Like, I'm glad you are confident, like, tell me more. And so it's just, we actually give them, the actual phrasing to kind of start the conversation. This is what we practice during the training as well. And then finally, our future aims really are, this is our nice like adaptation circle of where we are. And, we're following the EPIS model of implementation really to guide how we're adapting this. And so the idea is that, again, you already have the evidence-based intervention, but it's really about how to like incorporate that in a system or a setting. And so we've already started with exploring to understand, the needs of the community. We prepared by, really like focusing on the 5 R's instead of the 5 A's. And then now we're trying to implement it, to think about how effective is this? Like, is it effective in increasing knowledge? I actually don't have these results up here, but we did just run some pilot trainings, and they were effective in increasing the knowledge and the confidence of community health workers to do brief counseling for smoking cessation with their patients. And so we have, our next like big phase to really think about, how do we sustain this? Where would this be housed? How do we really scale this so like many CHWs can get this training? So I just want to shout out my wonderful lab who helped in creating this project, and acknowledge all the community health worker organizations and the community colleges that, train community health workers that helped during this project too. I am all done, right on time.
Wonderful. This is so impressive, Dr. Tan, the way that your team has moved this through all the formative research steps and implementation science steps, and built it in such an insightful way. I want to pass this to Rachel to introduce some questions for our Q&A.
All right, thank you so much, Dr. Tan. Okay, at this time, we can take a few questions from our listeners. As stated earlier, please input any questions in the chat box by addressing it to panelists and attendees so everyone can be involved. If all questions are not addressed, please feel free to contact our presenters at their emails shown on the screen. Okay, so our first question is, can you give us some examples of the types of organizations that support hire the CHWs? Sounds like they are from other community organizations in Chicago.
That's an excellent question. They actually are employed in a lot of places. So community-based organizations definitely have, that's the larger proportion that employ CHWs, but there are hospital systems that employ them. UChicago employs like a handful of CHWs too. When I started this project, Northwestern had maybe one, but it really is variable and it depends. Many times I will say that they are often, like the UChicago CHWs are employed under our nonprofit C3 arm. And so oftentimes they are, hired as a result of like grant funding or philanthropic funding to focus on a specific disease or disorder. And so, so because of that too, there's still like the transient nature of like their careers and workforce because, grant funding ends and then things like that. I know CDPH, the Chicago Department of Public Health, actually has maybe about like 105 in their chronic disease prevention department right now that they were able to hire a lot from doing COVID contact tracing, and now they're retaining them to do chronic disease prevention. And so it really is variable. So it's across like, state, government, hospital, but also community-based organizations. But Sinai Urban Health Institute has been working like for 20 plus years with community health workers and really like empowering this workforce. They did do a report like maybe in 2017 that they surveyed organizations that employ CHWs. And so I can definitely find that and share, with you all to kind of show the landscape of who's employing CHWs, how many clients they're seeing, and things like that across Chicago.
Okay, thank you. All right, next question. Was there a preferred format for delivering the motivational interviewing by CHWs? One-to-one, in person, telephone, group sessions, Zoom, etc.?
That's a great question. Not particularly, because I think that what we found is that it depends for their client what they're going to do. So they really wanted to kind of keep it open. The idea is that we're trying to just like kind of give them tools to like for them to be, to have the knowledge they need as they do what they would do anyway, right? And so, so instead of kind of having like, okay, we're going to design this like group-based motivational interviewing program, we're just like, here's how to do motivational interviewing. So you might see a client on Zoom, you might have a little group session, with family members, so it's like the idea is that, the mode that they deliver their care, that is flexible, and they really that really came out in our data is that it is flexible, and they don't that is what's the beauty of their their relationship with their patients. But they did want things more so kind of like, we want a handbook to take with us, we want handouts to give to our patients, and that's what came out in our data and our focus groups, is that they really did want materials, but how they delivered it didn't really come out differently.
Okay.
Yeah, do you mind?
Yeah, and Anna, please.
Hi, everyone. I'm Anna Wilkins, and I've been working with Marsha on this project for some years. And I think exactly what Marsha said is accurate, really, because their goal is to meet their patients exactly where they are with the needs presented, to improve access to care. Ideally it's in person, of course. If you can deliver motivational interviewing as well as the rest of your health education, it would be great if it is in person, and many do. And then the settings can vary for that. There's privacy issues that come into play with that. But they have, coming out of COVID, there were a lot of visits that were conducted on Zoom. They do things by telephone. They may check in by telephone. And one of the goals for us with this project and with the curricular materials is really to provide them a slew of resources, plus examples that they could use as they see fit. And one, I wanted to jump on here to say that one of my favorite recommendations or feedback from one of our CHW focus groups was that she remembers actually going into a patient's home and the patient smoked, but the grandchild, either the child or the grandchild, really wanted the patient to quit and came into the room, and it, in terms of being able to react and address the needs, the CHW can then leverage that. One huge motivating factor and why smokers or people who smoke might quit are family members, wanting to be around for grandchildren or kids, and that can be an example that they can use. And so one recommendation is that we provide coloring pages for kids that are around smoking cessation or healthy lifestyle, etc. And they can kind of be an additional motivating piece that is included in the effort for a patient to quit smoking.
So that's interesting. So home visits are oftentimes what CHWs do, right? So breaking down a lot of transportation barriers and safety barriers by going to meeting patients where they literally are. And then having that family context built in too. Fantastic. Okay. There's another question, Rachel.
Yeah, last question. Do any of the CHWs have firsthand experience with smoking and quitting? Would patients respond better to advice and information from someone who has smoked and successfully quit?
Yeah, so definitely, especially the ones that we work with, like in the focus group, there was one who, identified as a former smoker, and also some of them could have been currently smoking themselves without, identifying. And yes, there, is research to show that there, is like, the peer support or like, the model of like, people having gone through the experience before, it's like supporting you through is like very helpful. And so, yeah, so the answer to the question is yes. But I, also will say that the CHW still develop their own relationships with patients. So in like sharing shared experience may be a way that you do that. And so for the one who acknowledged that she smoked in the past and she quit, like she really uses that as like a tool to connect with her patients. But then others who might not have, they may connect in different ways, right? And so I think that that is the beauty of this CHW model is that they find that connection in different ways. And we've gotten feedback that some people some community health workers are viewed as kind of like a cousin, or like a sister. But some of them are called doc, like, oh, what's up, doc? Because you always talk about health stuff with me, so they call them their doctor, And so it really just depends, and that's how they respond and are flexible with like how they develop these relationships over time. And that's like what's so amazing, that can develop these really close relationships in the ways that they see fit, because it's not like a one size fits all. Like, communities with low SES, each individual is not the same. Each experience, each neighborhood they live in is not the same. And so that's like why I really like the idea of this flexibility and the personalization, is because it is needed. Although we know the general concepts of like recurrent stressors, recurrent traumas, like low resources, the way that looks to like motivate patients to connect them might be different on an individual basis.
Wow.
And I think that question comes up. One thing that we do discuss in the curriculum training is that especially for CHWs who may not have had who may not be smokers, or may not smoke, may not have a history of smoking, often that question, if a patient is posing that question to a health educator, to the CHW, it's really because they want to know if they will be understood and their experience will be understood. And so as Marcia was saying, one great thing about CHW is being trained and then able to provide smoking cessation is there's so many ways that they can reflect back to their community members and their patients that they do in fact understand their experiences, what they're going through, how difficult it is, and they can use different pieces of the connection to the community in order to connect with the patients.
Yeah, and that's a big key of motivational interviewing is
Right.
being non-judgmental, allowing the patient to share like where they are, and then validating that the patient is where they are, and that's fine, right? And then kind of like, you know, asking permission to kind of move on, to like kind of continue on the conversation and things like that. So.
All right, thank you so much. Oh, there's one more. One more question, and then we will move on. CHW are members of the community who are trained to provide basic health education. Oh, this is just a comment, and services to their fellow community members. Thank you.
Thank you. Yeah.
I'll now hand it over to Dr. David. If you think of any more questions at any point, please insert them in the chat and we'll make sure that Dr. Tan gets them. So thank you so much.
Very good. Wonderful. Well, thank you so much again, Dr. Tan, for an incredible lecture. Now I'd like to introduce our three expert panelists who will join Dr. Tan and I to provide some additional insights on the implications of this research for health equity. And so first, I'd like to introduce Dr. Nancy Zhao from Rosalind Franklin University. She's an assistant professor, Department of Psychology. Anna Velez-Wilkins is a senior research and evaluation consultant in the Department of Public Health Sciences at the University of Chicago. And Dan Friedberg is an associate professor of psychiatry and behavioral neuroscience at the University of Chicago. So welcome, panelists, and thank you so much for joining us today.
Thanks for having us.
Thank you. So for the next segment, I'd like to talk about the implications of the work that Dr. Tan presented for health equity, first in our health systems and then in our community, then to talk about policy change to better promote and support this kind of work in a scalable way, and then for advancing translational science. So first off, on this question, this goes to all of the panelists and to our speaker. The implications of this community health worker model that clearly has developed a lot of trust and comfort in the community and connection that's personalized. How can this be disseminated in our health systems more broadly? And thoughts about that based on your experiences would be really powerful. To any of you, I can pick on somebody, but Dr. Friedberg, what are your thoughts about, say, U Chicago medicine and community health workers connecting more with, this is a lot of the work that you do in your research, but with clinicians?
Well, I think this is, thank you, Dr. Tan. I mean, it was a great talk, and I think certainly a very important topic and very relevant to the work that we do at the university in our program. One of my jobs at the university is I'm the co-director of the tobacco cessation program along with Andrea King. Andrea's really been a leader in the field for many, many years and kind of helped spearhead the Courage to Quit program, which has been widely disseminated across the Chicagoland area. And certainly having community health workers, I mean, what I took away from this talk is there's this level of engagement and authenticity with community health workers that is really valuable for reaching folks who indeed are historically underserved. And not just underserved, and this is something that Dr. Tan's presentation was, I think, just spot on in terms of our experience clinically, not just underserved, but targeted by tobacco companies for exploitation. So these are folks who, you know, in like say the Black community, these are folks who have been targeted for exploitation by the tobacco companies. And so there's a lot of room here to expand services. There's this level of authenticity, I think, that's excellent. And I also really love the emphasis on the motivational aspect, which I think is I'm happy to talk more about that, but I think that really jumped out to me as being something that's extremely important.
Thank you very much. I'd like to ask Dr. Zhao too, in the North Lake County region, your sense of how much community health workers are really being fully mobilized and leveraged for this, and what opportunities there might be.
Yeah, I think I love Marsha's talk because I think it really integrates kind of like the patient to healthcare side of things, right? Like getting the patients connected through this community health worker stage. But I think it's really also important, and what's missing oftentimes, Marcia kind of hinted at this, is the connection of having community healthcare workers actually in our healthcare systems, right? That like helping healthcare systems understand the power and the need of these community healthcare workers. That I feel like very much the healthcare systems are focused on physicians, focused on nurses, MAs, and more of like people that are traditionally built into our systems, and less of this integration of like, how can we really target and serve our community, especially people who are oftentimes might not have health insurance, don't feel comfortable speaking with their doctor because of cultural factors, can't speak the language. So the community healthcare workers are people that are very much like integrated. And so it's not only this importance of what Marcia's doing of like really helping our community and the members of the community understand and have this access to healthcare, but also building that bridge additionally within like admin systems, or connecting the healthcare workers to physicians, nurses, pharmacists, kind of like how that worker can also be integrated, I think is so important as well for healthcare systems to understand of how they can use this way to link and build upon building more equity in our system for the community members and our patients.
I actually have an excellent, I want to post a link to a paper that is called Clinical Integration of Community Health Workers to Reduce Health Inequities. And this idea of like kind of showing best practices if a healthcare system were to integrate the community health worker model. And hopefully, I think it should be like free access to everyone once you click on it. But thank you for saying that, because that did remind me of that paper. It's from Sinai Urban Health Institute, but it's just kind of like the considerations if you are bringing a community health worker program into your healthcare system.
Yeah, and I feel like a lot of us, like we have a new Center for Health Equity here at Roslyn Franklin that's trying to kind of do this bridge, like helping organizations, community organizations, find community workers and like link with patients, and kind of how that can be linked into research, into healthcare systems, because research is an additional component, right? Like Marcia brings up, that we need to understand these communities. We can't just treat them. We have to also do some assessment, do some survey, now analyze what our surveys say. So there's the link between like healthcare and research and our community organizations to really be able to support our patients as well.
Yeah, and you bring up the issue around population health. There may be many patients who aren't our patients who are there in our catchment area, and how health systems can speak the language of population health and measure improvement in outcomes is something that community health workers could teach them a lot how to do, but also to be in the right place to collect the information too.
Yeah, I feel like it's hard with healthcare systems because you have to try to like almost overgeneralize, right? They want to target that population level, but community health workers do such a great job of the individual level. And so I think healthcare systems often struggle with, well, we want to make sure we cover as many people, but then oftentimes the individual level gets forgotten because they're trying to overgeneralize so much of how their services can matter.
Right. Well, reconnecting that with primary care, it could be very powerful if it was scalable, and built into the system. Okay.
I think there's a lot that could be learned from international community health worker research. There's a lot, in my reading of the literature, a lot of the model, the CHW model, is used fairly extensively in a lot of developing countries to reach rural populations, for example. So I think we are, we have arguably one of the best healthcare systems, well, sort of, in the world, just in the States. But then addressing health equity is a relatively newer goal that we have across the board. And so I think there is a lot to learn from the international model of how there's implications both here in Chicago, which is obviously it's an urban center, and reaching disenfranchised communities and underserved communities, but there's also there's so much work out there about how we can also reach out to rural populations as well, just from a health system standpoint. Often they don't have resources to the same degree that we obviously have here in Chicago. So I think there's great potential for CHWs and the CHW model integrated into health systems sort of across the board.
It's a really excellent point. I think that, for example, in Alaska, many villages have community health workers who serve as primary care practitioners, and
Right.
the physicians fly in once a week or something to see the highest risk patients. But as a model to take care of the whole population, it seems to me that this is catching on and people are starting to realize the power of it. And what about reimbursement for CHWs? Is there, in the post-COVID era, are you aware of any? I know for contact tracing, but what about for chronic disease management?
I get that question all the time, and I don't know the answer. I know that, like, for instance, I also am doing a project with advanced care planning, like with community health workers in an oncology setting. And, you know, so for instance, it's like they can be reimbursed for doing like the 30-minute conversation about advanced care planning and stuff like that. I don't know the extent of how they are reimbursed or what, you know. But that is a good question. I think that's the question of the day for a lot of people.
So cancer centers are hiring CHWs for advanced care planning purposes.
So what we're working on, again, like kind of doing a similar thing of like, how do we integrate CHWs to support this process of this like longer term process of advanced care planning, because most of it happens in oncology settings. With the oncologists actually having these conversations, but then the priorities of the oncologists are, you know, treatment of the cancer and the disease. And so, you know, the conversations aren't happening like regularly or readily or like first. And so we're like, okay, well, how do we just kind of support the CHWs to fill in those gaps to make this a continuous thing over time so that nothing gets like lost, people don't get, you know, like, or as they change their mind, they can have that personal conversation with the CHW. The CHW can come back to the physician, you know, so we're trying to figure out, and I see it as that too, like the CHWs really help like integrating them to support, you know, those gaps, right? As opposed to like not taking over function, but like supporting that function, right? And so that question is to like, what does the reimbursement model look like? What is, you know, can they, and I don't know the answer yet, but I am trying to figure that out too.
Thank you. So then going beyond health systems, what are some of the implications of this for health equity in our communities from the CHW model? I think kind of independent of health systems, do you see, Dr. Tan, this growing into a larger program?
This was the impetus of this was, like you mentioned, Sean, addressing the people who aren't already in the healthcare system, right? So the people that might not already be our patients or be established. And so like I really do think about because the CHWs too, they aren't just hired in a hospital, they are hired sometimes in these like, you know, grassroots settings and like these, you know, community-based organizations like independently. Some of those are connected to larger hospital systems, some of them are just not. And so I do want to think about sustaining this program for community health workers, especially as they have touches with patients or people who will never be potentially, hopefully that's not the case, but potentially never be seen, you know, by a provider. And so that's my big question mark, that my big puzzle of how to sustain a program like that if it's not based out of a healthcare system, because that's like the easiest way, I think, to house and like expand and kind of like you know. But yeah, so that's the question. And we're working with the CHW training center right now to kind of think about how to get this program out to people, but also like on the research side, it's still kind of like challenging to think about how do you assess the patient outcomes? How do you assess the uptake of this? Like, are there actual changes in smoking quit attempts and like quit rates, like based on training this workforce? So that's kind of what the lab is like, you know, like kind of working on ongoing.
Right. And then to have a trusted community-based organization that different groups of people based on their language and their heritage and other things is really important too, isn't it? For people to feel comfortable speaking the same language.
Absolutely.
So the Institute for Translational Medicine, part of what the charge is to build a community-based research network that includes CBOs as well as practice-based research networks. So figuring how to do this, and there's also a training program for CHWs from Malcolm X College. They have a training program.
We've been working with them, yeah.
Yeah, where ITM is going to provide some research training opportunities to be citizen scientists as well. So there may be some, research
Oh,
matrix that could
yeah.
develop. It could be a good experimental, place for doing this work.
Oh, yeah. I'll follow up with you.
Excellent. And then somebody mentioned, was it Anna, CDP, the Chicago Department of Public Health, and they have,
Maybe that was me.
that was you,
Yeah.
okay. And can you say more about that? Is that they're keeping the contract tracers on, but also which kind of chronic disease, like type 2 diabetes, or?
Yeah, I think that's why I had this conversation maybe like maybe in January or February. I met with someone just about this project because they heard me give a talk about it. And I think they're still kind of establishing their priorities as an office. I think they're the Office of Prevention, I want to say, or Chronic Disease Prevention, and they're establishing their priorities right now. And I'm like, tobacco cessation should be one.
Yeah.
But they, because they had a lot of funding, they got a lot of funding, federal funding from during COVID for contact tracing. They had like 800 or something. They trained and like found like 800 CHWs, which is like amazing. But they really are really trying to build up this workforce to for them to really have like careers where they can like move up and things like that. So like the expectation is not, some of them might not be in this position for like long term. So they're really trying to figure out like a sustainable model for that. And then so they were able to retain with some funding about 100. And so now they have 100 who can do some of like the programming that they have and like whatever. And so I'm like, I would love to train those CHWs. And so so I think they're trying to still figure out what their priorities are for like the next like fiscal year or whatever, however they do those things. But
Interesting. And then the new mayor is proposing some social spending too. So I'd be curious to know what that budget looks like and whether that includes CHWs.
oh yeah.
Yeah, fantastic. So this segues into implications of this for policy change to promote equitable care and outcomes. This is a broad area, but in terms of reimbursement, in terms of supporting things, in terms of infrastructure, maybe connecting more of the dots across the geography of the CBOs. What are your thoughts about policy change you'd like to see informed by this? I mean, this looks incredibly powerful as an intervention. What's it going to take for payers, and what kind of policies do you think we need?
I could just say personally, I think there's independent CBOs that are doing like really good work, like addressing usually like very specific needs, right? So you have food banks, for instance, that are focusing on food insecurity, and then you have, a housing one or like an immigration one, right? And so you have all of these things. They're just out of Chicago, they've kind of developed programming to kind of, we have something called like Now Power Community RX, where it's like you kind of get prescribed your, to like where you can like address that social need. So like things are there, but there's still no true connection between CBOs. And I would love for that to be more at like a county level, or like, or some kind of level where, because I think a big problem is that I've always wanted to create a large database like management system so you can track community members and individuals as they go to these different services and seek services in different places. And the EHR, like the idea of the EHR that goes across different healthcare systems, but for community-based organizations. But the problem is that it costs money to like get some of these like databases. CBOs don't have funding for that. And there isn't like a larger kind of like, overseer of those things. So that would be mind of kind of like tracking people in this like social service area, but also with health, like health outcomes with EHR, kind of like combining like an EHR system with like a social services tracking system. But that will have to be conducted at a larger level, not just independently from like an individual CPO, if that makes sense, right? And having some kind of incentive to do that evaluation and tracking, like as they see people and people come into their organizations, you know, something that was just more, I guess something that's just more, you know, not just, you know, independent, but more like collaborative. And I think, Sean, you kind of mentioned that as you're talking about like ITM and some of the goals. But that's always my, that's always what I want to see, basically.
Yeah, to deal with the fragmentation and have a cohesive system that I think it's going to take some policy change to be able to do something like that, because you have these big electronic medical record companies that probably don't want to make the licenses free.
Exactly.
But if that's underwritten by, yeah. So, okay. So the next question is, what are the implications of this work for advancing translational science, or the science of translational science? There's some opportunities here, it seems like, to build on it. You're clearly building a foundation for about 3 R01s here, it looks like. So
That makes sense.
where do you see this work going next, and what opportunities are there for our community of investigators to what are the gaps that we should be looking for scientifically? To all of you, actually.
Yes, I will let other people.
Yeah.
Mute myself for now.
Let me speak briefly. Oh, no, go ahead.
No, okay. I was just going to put in a plug here. So, you know, when COVID happened and we took our Courage to Quit group at the University of Chicago and we had to go virtual. We were fortunate. We were able to very quickly transition over to that format. And regarding research on outcomes, you know, the group has been kind of shifted in focus to target underserved populations. And so when we started crunching the numbers and looking at our group membership, we realized, you know, most of our group members are lower income folks with multiple medical comorbidities from the South Side, traditionally an underserved population. So Dr. Emma Brett, who's works with our group here at the University of Chicago, just recently published a paper on some of the outcomes from the virtual group. And another notable feature of that was, in terms of practical implications, was we've adopted a rolling format. So it's kind of like come as you are, stay as long as you want. Almost like, you know, if you ever heard AA, Alcoholics Anonymous, they say, you know, the only requirement to attend a meeting is a desire to stop drinking. Our only requirement is a desire to learn more about quitting tobacco. You don't even have to be ready to quit today, right? You don't even have to promise us you're going to quit. You know, you just have to be interested in learning more. And I have the data right up here, the paper that was recently published just very recently, a few months ago, you know, and we had really good attendance, and people showed a 30% reduction in their average cigarette use, which they were all very happy about. Most of our patients we found kind of on the road to quitting altogether will try to reduce. That seems to be the most popular way to quit. So I'm just thinking, you know, in terms of Marsha's presentation here, listening to it and thinking about, you know, there's some things that we've had very good luck with at the university in terms of meeting some of these disparities head on. So it's been quite successful.
So I'm hearing that there's maybe some new frameworks for cessation that might be more culturally aware of what.
Yeah. Yes.
So.
Absolutely. And, you know, we've had actually pretty good luck with most of our patients have Medicaid or Medicare, and they seem to cover those tobacco services 100%. At least we've never had any complaints. The biggest trouble, funny enough, or maybe not funny enough, is with the private insurers, where patients will all of a sudden get a large bill for copays that they can't afford, you know? And so I think reducing barriers, having this service available to the most amount of people, well, who's going to pay for it? That's a question that we do have to answer. Yeah, we've kind of reconfigured the materials to make it easy for patients to come and go, most of them do stick. I mean, to be honest, we have a lot of patients who come and stay for several meetings, but if they're brand new to the group, they can just slot right in. We get them started and they can stay as long as they find it useful. So.
Great. And Dr. Zhao, your thoughts?
Yeah, I think translational science is so important in the world of tobacco use because there's people kind of doing very segmented research in terms of policy versus clinical treatment versus basic science. And there needs to be more connection, pulling areas from of research from different areas to help clinical outcomes improve. So for instance, I think the federal policies that are going on with menthol cigarette ban, I think that's important for community health workers to be aware of because potentially they're going to be largely involved in underserved populations and vulnerable populations are the ones that are largely using menthol cigarettes and will be impacted by that policy. So helping our community healthcare workers understand that this is something to be mindful of. Maybe healthcare systems and community organizations need to hire more community healthcare workers if that policy goes into is implemented, because there might be a lot more people trying to quit smoking, or there might be more people being involved in switching products afterwards. So education on what if you switch to e-cigarettes, what if you switch to a non-mentholated product, what if you switch to another type of tobacco product. So helping kind of the community healthcare workers be appraised of what's going on with tobacco regulatory science and public health at large, I think is really important. And then also from the other side of things is pulling in, there's a lot of really great research going on in basic science to help us understand why these individuals might have a harder time quitting smoking, because what research has shown over time is largely the people quitting smoking are non-menthol individuals, because the rates are going down overall, but the proportion of menthol cigarette use within smokers is increasing. So that means that usually it's probably the non-menthol smokers that are actually quitting. And so why is this happening? And kind of what a lot of my work and what I'm interested in is pulling in from the basic science side of things of, menthol has been shown to slow nicotine metabolism. There might be risks for increasing inflammatory biomarkers in our blood, which is increasing the risk for cardiovascular disease or lung disease. And so kind of understanding what the implications of these actual products are, not just understanding, because smoking in itself is often utilized as a broad category, right? Physicians often ask, do you smoke? And that's it. There's less of like, what do you smoke? And then actually, what does that mean? So smoking a non-mentholated product versus a mentholated product is very different. Oftentimes in clinical care, we tell individuals, hey, you might not want to quit smoking, but how about you switch from a mentholated product to a non-mentholated product? And people are more willing just to make that step. And oftentimes people will quit from that. That is, a lot of people have cited that is the reason that they end up quitting smoking, is just by switching flavors or reducing their preferred flavor, even in e-cigarettes, switching from a sweet flavored product. We've done a lot of stuff looking at how flavors and perceptions of flavors, people that largely influences how much they smoke. So people switching from like a fruit flavored e-cigarette to a tobacco flavored e-cigarette, people automatically reduce. And so they don't try to quit smoking, they don't try to reduce, but just from that perception and their sensations they're getting from the product automatically reduces their use of the product. So there's like a lot of other ways I feel like that we could fit in this research that we're doing, from tobacco regulatory science with public policy to the basic science area with biological work in cells and mice, that could actually influence what we're telling our patients and the community healthcare workers to educate them to better clinical outcomes. So I think there's a lot of room and need for all these sides to communicate. Because especially I notice in the tobacco world is people are very siloed. Like you kind of do tobacco treatment work and oftentimes people just continue doing tobacco treatment work. And so being able to pull information from these other areas, patients find it really interesting because they've never heard of those things. Sometimes it's just like, I'm told to quit. It's bad for me. I know it will increase my risk for cardiovascular disease, for lung cancer in the future. But I didn't know this thing about menthol, like what menthol can do biologically, why it's harder for me to quit maybe than the other person who's smoking a non-menthol cigarette, why it's so hard for me to quit. So I feel like some of these little tidbits sometimes from using a translational science approach can really help improve our clinical outcomes for our patients and how we can bring that into our communities as well.
I agree completely. I just want to say thank you for bringing that up, Nancy, because the type of product is very, very important. And I love Nancy's research on looking at the effects of actually using methylated products versus not. And that's something that's really big in the Black community, is using little cigars, like Black and Milds and other products, not just a traditional cigarette, right? Or using papers from some of those to roll like other substances and stuff like that. So there's a lot of co-use and like mixed use and things like that. And interestingly, we brought that up in our focus groups about different types of cigarette or different types of tobacco products, and we end up not including it because I think that was something that wasn't new information, I guess, the CHWs. Like, it wasn't like they needed to learn what a little cigar was because they knew what it was, which is fascinating because they are part of that community too, but I just wanted to say thank you for bringing that up, Nancy, because it's very, very true. Our goal is really like, why is it so hard to quit smoking? That's kind of our theme of our program, and we do incorporate a lot of those things. Like we talked about the menthol ban and stuff like that, and it is not just one thing. It is like across the spectrum of policy, basic science, clinical, individual behavior, like all of those things.
Yeah, I find it fascinating, and sometimes talking with smokers or people who smoke, that they will not report smoking because they think really they're being asked about cigarettes, largely because most of the information out there is focused on cigarettes. Physicians talk about assessing primarily for cigarette use. Now they're assessing more for e-cigarette use because it's becoming so prevalent. And there's a lot of like community hubbub, I guess, in the way that's becoming like the hot thing to use, e-cigarettes. But people are largely aware, the physicians I've talked to are largely aware of all the other types of products and the impact of dual use. So largely other tobacco product use is in that dual category. It's rare that people are just using just cigarillos, or their perceptions of using it, they don't consider themselves smokers in a way because they're using it so infrequently. But in a way that there's no filtration, so the amount of like product that they're getting into their lungs, into their bloodstream, oftentimes is higher because there's no filtration compared to cigarettes when they're smoking those products. Same thing with hookah, or all these other types of products. Sometimes our community is less aware of them just because there's less focus on treatment and education of those areas. And so the FDA is also targeting now understanding what's the difference between little cigars, cigarillos, and premium cigars. What is premium cigar? How do you categorize it? That's not even defined largely officially. So the tobacco regulatory science side is really trying to understand how can we help our community by really figuring out better policies, not just like an individual level. Chicago's been pretty ahead of the times in a way that they've implemented a lot of things with like the menthol ban. They can't sell menthol cigarettes around certain radiuses around schools. So they tried to implement that to reduce the selling and targeting to younger populations. So Chicago's definitely been kind of ahead of the curve at a national level. So it'd be nice to kind of see that continue as well.
It's really a good reminder is for those of us who are clinicians to really be educated on the topics you're asking about and really know the community and who you're talking to, because I can, as Nancy's speaking here, I'm thinking, being a guy who specializes in substance use work generally, I'm sure I've had many patients in my career. We talk about cannabis use. Oh, how much I smoke? Yeah, I smoke about a blunt or two a day. They would not identify as tobacco users, I guarantee you. They would not say, oh yeah, I'm a regular, but they are, and I don't know if anyone, this might be interesting to know, maybe a sidebar, does anyone know how much nicotine, what's the nicotine content of a blunt wrap? Does anybody know? I don't know off the top of my head, but it might be interesting to find out. So yeah,
depends on how they're doing it too, right? Because they could be hollowing out cigars versus if they're rolling their own. That's very different.
Yeah. Right, exactly. Yeah, so it's really all about, when I work with my students, like, you got to educate yourselves, you got to know what you're asking about and what you're looking for.
There's a comment from Rachel. Rachel, did you want to bring that to the panel? It's okay.
Sorry. Yeah, sure. I'm just listening to this and it's just really funny. Listening to my husband, I hear him so many times speak about, what he has to go through to even incentivize some of his clients to do anything, hygiene, you name it. And that's because he's working with a lot of the population that's struggling with extreme mental health issues. So it's like anything, it's often used as the incentive to go, a cigarette, a little square, just to go to something that can then help them later. It's just really interesting to see people then dealing with just the addiction to nicotine as the issue. I'd never considered that because I hear it often as the incentive. So it's nice that there's a path past, step one, the initial barrier to then, even further improve their life.
I did work in substance use, generally sort of illicit substances, before I transitioned to focusing primarily on tobacco. And I would say that was the model, or we observed that as well, that when there were counselors, substance abuse counselors, who really wanted to get their clients on board with minimizing and cutting out quote unquote harder drugs, the incentive would be, well, instead of going and, smoking crack, why don't you just and literally physically give a packet of cigarettes as the incentive to not do the, again, quote unquote harder drugs. So that's I actually I don't know how much that is still the case. I'd imagine that is the case. I don't know if Dan, if you know.
Not off the top of my head, but certainly there's a kind of an economy around these things, right? So, certainly that I could see that being used as an incentive.
I think that's more for harm reduction. And
Right.
just to be clear, like that's what my husband usually works in, is harm reduction.
Right.
So, if there's a greater monster, then, that, is seen as the lesser, but clearly it's not. In the long term, it's not.
But it goes to those issues Dr. Zhao raised about why it's so difficult for patients to quit. And so practitioners, whether they're CHWs or physicians or APPs, et cetera, having the kind of insights to understand the biology, the sociome, the biomarkers of inflammation and chronic stress, and what happens with menthol. It's also important, but there's a lot of space for research to better understand that work, so we can better understand how to help patients. So
thank you for bringing up harm reduction, Rachel, because that is another area in our tobacco research that we look at too. It's not just everybody quit, like there are kind of like stages and levels to this depending on the population, right? And so that's why it's so complicated. So this addiction is so complicated too. And I will say I'm really interested in motivational interviewing in general, just because, from an individual patient perspective, like the idea really is to to get patients to understand how, to prioritizing, quitting or reducing, tobacco might be actually in line with whatever the patient's own personal goals are, personal health goals, right? And so the idea is that just kind of bring it to the surface to see, like, how is this related to what I am trying to do with my life or not do, right? And so it's not, again, like it's not a one size fits all thing for people, but it's just kind of like bringing it to light and helping them like kind of get there to see like how prioritizing this really could be, addressing a lot of the other, concerns that you have. So.
And don't underestimate the value in helping people realize that they can be successful. Most of the folks that we have in our group are older folks. They have chronic health conditions, oftentimes tobacco related, sometimes not. They almost to a person have just come in demoralized. I've tried to quit. I know it's terrible for me. I know this problem that I'm having health-wise is exacerbated or caused by my smoking. I can't quit. And so we work on harm reduction, maybe is not quite the right term, because we know that any amount of smoking is bad, but we work with them on reduction, right? Oh, well, maybe you could cut out a cigarette or two, and we have some strategies to help them do that. They start to build this motivation and confidence based on that. Oh, wow, And I like to frame things in terms of percentages. Wow, you cut 20% of your cigarettes, 2 cigarettes a day, but that's 20%, of what you were smoking. That's pretty impressive. And look at the trajectory you're on. So really powerful techniques to kind of meet people where they're at, but also kind of keep them moving in the right direction. Absolutely.
Well, this has been a wonderful seminar. Thank you so much, Dr. Tan, Dr. Zhao, Dr. Friedberg, and Anna. Rachel could go to the next slide if we could. But it's clear that this model that you've developed for training community health workers is very powerful, and it's kind of in that space that the big gap is how to connect with the patients who really need treatment. And that the demographics have changed so much that tobacco control work is health equity work. It's the
100%.
same thing.
Mhm.
Intersectional communities and minority and low SES communities have a much higher burden of lung cancer, as well as using multiple tobacco products. So this work is so important from a public health standpoint, and I'm really excited about your generation of researchers and what this is all going to lead to. So thank you so much. So for any questions, comments, concerns, or interest in presenting at a future seminar, please contact me. My email is there in the slide. Rachel, I believe you're going to put a link to an evaluation in the chat. Is that right? Right there. So there is a survey to provide some feedback to us on the seminar today. Thank you, Rachel. It's in the chat, and we'll send it out by email as well. And then we will post a recording of this session on our YouTube channel. We can send a link to that as well in the follow-up email. And then don't forget, there's CME credit to be claimed. So we encourage you to go ahead and do that. And so I'd like to wrap it up and say thank you very, very much for a really outstanding seminar. And hope you can all come back and visit us sometime. Okay.
Thank you for having
Thank
us.
Thanks.
Thank you.